We're going to move on now to the effects of inhaled anesthetics on the central nervous system. And I'd like to give you a view of this that relates to a simplistic analysis of the EEG. I suspect that most of you, if asked, well, what do anesthetics do to the EEG, would be a little bit uncomfortable about answering. But the answer is really very simple. You sitting here have an EEG that looks like this. See? That's an EEG that you have. When you go to sleep, that is when you're anesthetized, sleep being a euphemism for anesthesia, these waves get bigger and they get slower. And that's what happens with anesthesia. And they get slower and slower until finally they go to sleep and they don't do anything. And you get burst suppression. And anyone, in fact, can look at an EEG and get some element of the idea of where you are in terms of anesthetic depth, just with this simple concept in mind. Here's an analysis of what I've just shown you in terms of the burst suppression, those flat waves that occur. As you increase the anesthetic concentration up to, say, 1¼ Mach of desflurane or sevoflurane or isoflurane, you get no burst suppression. And then at 1¼ Mach, you start to see burst suppression. And you get more and more of it as you go to deeper and deeper levels until you get nearly 100% of burst suppression. That is, you get a flat EEG. It makes our neurological colleagues very nervous because a flat EEG means the patient's dead. Fortunately, that isn't true as far as anesthesia is concerned. And what you also notice here is that if you're taking the Mach value and including in that nitrous oxide, you see that the curve shifts to the right. And really what's happening is that nitrous oxide, although it adds to Mach, doesn't add at all to this capacity of anesthetics to affect the EEG. Let's see a couple of EEGs in the operating room.
Can you liken this pattern to anything that we've seen before?
Well, we saw a similar pattern when the patient was somewhat awake but sleepy, with the BIS reading in approximately the 80s. We see the alpha waves situation.
What? Look at this, quickly.
Well,
what do you see?
That was some burst suppression that we just saw there.
Exactly correct.
And in addition, we can look at the amount of energy that's in the EEG. The amount of energy that's in the EEG at certain frequencies can be looked at in terms of the spectral edge frequency. That is, we can look at the edge of the highest frequency, the edge as the highest frequency at which we find activity, either 95% of the activity or 100% of the activity. So we'd say that the frequency in hertz, 20 cycles per second, is what we're going to find in the awake person. That is, the awake person has frequencies that are up to, but not in excess, of 20 cycles per second. All the energy in the brain waves that we get goes up to here. And then when we give anesthesia, that edge goes down. And all the energy is in lower and lower frequencies and below. That could be a measure of the depth of anesthesia if we liked it. Then we got some other effects of anesthesia. We've already noted that some anesthetics produce convulsions. And these are which? Sevoflurane and enoflurane. They're rare. They're infrequent. What precipitates them?
Hypocarbia.
Hypocarbia is one thing. What else?
Greater than 2 Mach.
Higher concentrations. And apparently a sudden imposition of those higher concentrations. And what else?
Pre-existing seizure disorder.
Pre-existing epileptic disorder. That's right. Now those are the things that you have to remember. So if you've got a patient who has a history of epilepsy, you want to be a little more careful about giving sevoflurane. Are they dangerous? Are these convulsive manifestations dangerous? There's no evidence that they are. They occur, but there's no evidence that they produce cerebral injury. Whether they're connected to postoperative agitation is unclear. And that's something that's been speculated, but without any particular evidence, any direct evidence. Let's talk about monitoring for protection of the spinal cord. How are you going to monitor to protect the spinal cord? Say you're going to do an operation on the spinal cord. You do some straightenings of spinal cords here. Take a crooked spinal cord and make it a straight one, or a crooked vertebral column, make it a straight one. What's the problem with that? What's the risk in that?
Cord ischemia.
Cord ischemia, that's right. The distortion of the cord may compromise the circulation of the cord. So how are you going to determine whether that's occurred? Because it isn't worth the price, is it?
No. Most common way is somatosensory evoked potentials, or you can use motor evoked potentials.
Okay, and tell us about those. What is a somatosensory evoked potential?
Somatosensory evoked potential measures the integrity of the transmission of nerve impulses from a peripheral nerve all the way up to Brodmann's area number 4, the postcentral gyrus, or actually Brodmann's area 512 of the postcentral gyrus.
So if I were to ask you to measure that, what would you do?
Well, if you're doing upper extremity testing, you could test, let's say, the median nerve is most commonly used, and using stimulation of median nerve and then measuring the impulse on the scalp through cutaneous electrodes.
So you just see whether there continues to be transmission through the cord.
Yes, sir.
Okay. And what do potent inhaled anesthetics do to the somatosensory evoked potentials?
Well, they can affect either, I believe, the amplitude or the latency of the evoked potential.
And do all of them cause depression?
To some degree, but some more than others.
Some more than others. Not all animals are created equal, right?
Correct.
All right. So here are sensory evoked potential amplitudes, and as you said, as you increase the concentration of anesthetic, these decrease, and that's true for desflurane, sevoflurane, and for isoflurane. The one anesthetic that some people have expressed concern about is not shown there. What's that anesthetic? Nitrous oxide. And nitrous oxide may cause more of a profound depression when added to sevoflurane or isoflurane than the sevoflurane or isoflurane by themselves. So if you've got a problem with somatosensory evoked potentials, you may want to avoid the use of nitrous oxide. And let's see now a demonstration of somatosensory evoked potentials in the presence of a potent inhaled anesthetic. Jennifer, what can you tell us about this case?
We're doing today is an anterior-posterior spinal fusion on a 9-year-old child for scoliosis.
And one of the problems with that is the amount of blood loss that you may achieve, isn't
Right,
it? How are you dealing with that problem?
Basically, we're doing deliberate hypotension. What we're trying to do is lower our blood pressure here to decrease the amount of blood loss. And the way we're doing that is we're doing a fentanyl infusion. What we're also doing is volatile anesthetics. And what we do is we have Seva going in at half a MAC. And what this does is it allows for deliberate hypotension, but it also allows for SSEP monitoring.
What's SSEP?
Somatosensory evoked potentials.
So that allows us to determine whether the surgery is imposing on the spinal cord in a way that would cause damage to the spinal cord.
Right.
And the SSEPs are okay with this, is that right?
Yes, this should be preserved with half a MAC.
Okay, that's very good. Well, let's go over and see if they are.
Okay.
Can you tell us what we learned from the somatosensory evoked potentials in this case?
Basically, we have a picture here of pre-opening. And from the subcortical structures, we have a measure of the SSEP. And the distance from here to here is the amplitude. And when we go to post-opening, we see the differences from here to here. So what we can see is that with deliberate hypotension and sevoflurane anesthesia, we can still maintain cord perfusion and monitor the SSEPs.
That's pretty good. That was with a half a MAC and considerable hypotension, wasn't it?
Yes.
Excellent. Let's move on to cerebral hemodynamics and metabolism and intracranial pressure. What do the potent inhaled anesthetics tend to do to these factors or these parameters in the brain, what do they do to metabolism? Decrease metabolism. And what should that do to cerebral blood flow?
Decrease.
It should decrease it. What might it do to cerebral vascular resistance? What should a decrease in metabolism do to cerebral vascular resistance?
Increase.
It should increase it. It should increase it. And in fact, cerebral vascular resistance tends to decrease. Cerebral blood flow tends to either stay constant or increase. Metabolism certainly decreases. And intracranial pressure, particularly at higher concentrations of anesthetic, and perhaps more with desferrine than with isoflurane or sevoflurane, will tend to increase. At concentrations of about 3/4 of a Mach or less, there really is a nominal or no significant clinical effect of any of these potent inhaled anesthetics. There's an increase in cerebral blood flow which primarily occurs only if the blood pressure is maintained at normal levels. If it's allowed to decrease, you may in fact find a decrease in cerebral blood flow with anesthetics like sevoflurane or like isoflurane. As you can see, there isn't much to choose between those anesthetics in terms of their effects on cerebral blood flow. Finally, the potent inhaled anesthetics may benefit our patients by protecting them against ischemic insults. And that's probably true of all the potent inhaled anesthetics. Desferrine may have a greater capacity to do so, perhaps associated with a slightly greater increase in cerebral blood flow and associated cerebral effects. During temporary middle cerebral artery occlusion, desferrine is associated with a more sustained brain PO2 than is the case with an anesthetic that's primarily based on etomidate or on thiopental. And the number of patients after such surgery with postoperative neurologic deficit is 0 with desferrine out of 6 and 4 out of 6 with etomidate. Now, this study wasn't continued beyond that. The significance level of the difference between those two approached significance but didn't reach significance. I would believe, and this has been studied, I would believe that all the potent inhaled anesthetics will have this protective effect relative to a drug like etomidate or a drug like thiopental. And they all will serve our patients well. I don't know how you can study in humans this sort of thing further, though. Yes, please.
When you say that, are you saying that that's above a certain Mach multiple, or does it really matter how much inhaled anesthetic you're delivering?
It will matter up to a point, depending on what is the basis for this. If it is an effect on metabolism, which might be part of this, there's a dose-related effect of desferrine or any of the inhaled anesthetics on the metabolic rate. But once you've gone beyond a certain point, once you've depressed the EEG to a certain level, there isn't going to be much more of an effect on metabolic rate. There is a slight effect, as shown by a study in which the inhaled anesthetics were added to a background of propofol, the propofol being sufficient to produce EEG silence. And you could get changes in hemodynamics and perhaps in metabolism as a consequence of that addition. So probably up to 1 Mach or 1.5 Mach, you achieve an increasing dose-related effect. And beyond that, probably no additional benefit. So the inhaled anesthetics are our friends. Was the question?
Yes. At this point in time, do you think there are many neuroanesthetists who are choosing this type of protection over thiopental burst suppression for temporary occlusion?
I don't know. It would seem logical that they might. Because the PO2 is better maintained with the potent inhaled agent than it is with thiopental, which has been studied.
Mm-hmm.
So cerebral PO2 measured with electrodes in the brain, in humans, is better maintained with the potent inhaled agent than it is with the thiopental in the area of concern, that is the watershed area of the occluded artery. Now, I don't know what neuroanesthetists do. I'm not a neuroanesthetist. And they may continue to prefer thiopental, which historically has been thought to be protective in these patients. But it would seem to me that this evidence suggests that it may be that the potent inhaled agents are more protective.
But could you get to a level, a MAC level, for these agents to be protective without compromising, you know, the cerebral blood flow and whatnot, and raising the intracerebral pressure, which I guess is gone because you removed the dura, but you know, the concept is you don't raise the MAC above you know, the desflurane or whatnot above about 0.75. So can you still achieve that running that MAC, or do you need to go above that?
It's complicated, isn't it? It's not a simple answer. You may compromise one thing in order to achieve another effect. At any rate, it's possible that the potent inhaled agents are our friends in many ways, including protecting the brain against cerebral hypoxia.